Right, so let's start. My name is Stefan Johansson. I'm a neonatologist in Stockholm, Sweden, and I would like to welcome you all on behalf of the 99 NICU team. Also present here today is Vicky Payne in the UK and Katarzyna Pietek in Finland, and Francesco in Vienna, Austria is also coming online, but he's in the hospital and is now doing some work. So today we would like to welcome three panelists, Joyce Ushia, Gemma Edwards, and Alex Scrivens, all from the UK. And we wanted to speak with them and learn about safe neonatal airway management. You may well have read the paper, a review paper that came out recently and that sparkled some discussions on Twitter and elsewhere. So welcome all of you. And I would now like to hand over the word to Vicky Payne.
Hello, thanks Stefan. Yes, I think it's really great that we've got the authors of that paper here today. I agree it created a little bit of a storm on Twitter, which I think is, as we were just talking about earlier, is not always a bad thing. So before we start, we wanted to ask all of you as attendees a few, just three short questions really, to see what your take is on some of these approaches in your practice really, and hopefully spark a bit of debate. So if you head to www.sli.do, sli.do / and then you can enter the code #99NICU VJC to start the voting. So I'll give you just a bit of time to head there and get another browser and bits open.
Is it active, Vicky?
It should be active now.
Now it's active.
Is it active now? Yes, it's active. So what is your personal plan B when intubation is not successful in a neonate? Oh, it's nice seeing the counter go up. I like things like this. Easily pleased. Any more for any more? Oh yeah, a few more coming in. How many attendees are there, Stefan? I can't see from my...
55.
Ah,
so,
okay. I'll give it a little bit more time.
Just a minute.
Any more for any more? It's about half of attendees, roughly.
Yeah.
Oh, a few more. Just need a little encouragement.
Yeah. And still no one has opted for tracheostomy. I'm kind of glad.
But they make it look so easy on the TV shows, Stefan.
Yeah, that's right.
On casualty and ER. So yeah. What is your personal plan B when intubation of a neonate is not successful? We've got a neck and neck, haven't we, at the moment? For the top two. Okay, so it looks like it's neck and neck. Oh, and neck for video laryngoscopy and laryngeal mask, both with 33% of 33 votes. So, next question then. Oh. Of our participants here in the audience, how many intubations do you think are necessary to acquire competence in neonatal intubation? And you can just type in a number. All double figures so far, all double digits. Oh no, we've got a 3. 50. And the bigger the number, the more people have typed that in. So the numbers that are appearing large, so 20, 40, 50, are currently the most popular. About half of people voted so far.
So, Gemma, Joyce, and Alex, you must come with the right answer during the discussion on this question.
20 and 40 are neck and neck. And 5 is getting bigger. Any more? We've got about 30-ish people voted. Last couple of seconds to make your voice heard.
People seem to agree that you need quite a few.
They do, don't they? Absolutely. So 20 and 40 and 10.
That's the take-home message. You need quite a few.
Yes, quite a few. We didn't have room to type that in. Okay, next question and final question. And then all the participants can have a short break from interaction. Do you think that neonatal intubation should be a mandatory competency for paediatric trainees? So for junior doctors undertaking their paediatric training?
Oh, this is interesting.
Was quicker to vote as well. Everyone seemed much quicker to put their answer in for that. Very interesting. So almost, I guess, 3/4 of people say yes, and well, about a quarter say no. Yeah, well, I think this might be a good time to maybe move on. I think, Gemma, are you going to give us a short presentation on your kind of the summary findings of your paper?
Yeah, that's fine. I'll just share my screen. I've got some slides. Yep. Let's see.
Is it working? It is.
Can you see it now?
It's coming.
Yep.
Yes.
It's up on my screen now. Can you see it?
Yep.
Perfect. So my name's Gemma Edwards. I'm a paediatric ST5 working in Glasgow in Scotland. Thank you for having us here today to speak about our paper. So we're going to speak about just a summary of our paper on safe emergency neonatal airway management. So to begin, simple airway adjuncts are not perfect. Face mask ventilation is usually effective for the small number of infants that need assistance at delivery, but they're not perfect, and they can be frequently complicated by airway obstruction and leak. And application can induce apnea in many preterm and some term infants. Use of oropharyngeal airways has traditionally been taught, but in the only RCT looking at their use in neonates, they were found to increase airway obstruction. And intubation is a typical escalation strategy. And intubations per trainee are very low, but despite this, they remain a mandatory junior competency in many paediatric curricula worldwide. And by the stage of being a senior trainee or consultant, the general expectation is that these clinicians will be proficient emergency intubators. But this is becoming increasingly difficult following recent advances in perinatal care. So there's now fewer infants being routinely intubated at delivery, more infants being managed on primary, less invasive respiratory support. There's increasing use of less invasive surfactants, and at the same time, increasing numbers of trainees, all competing for a reducing number of attempts. And we know that success rates are falling. So there's been 2 recent studies looking at recent success rates. One was an international study of over 2,000 intubations, and we looked at success rates in 4 UK units looking at over 200 intubations. And for looking overall at all grades of clinician, the success rates were very similar between the 2 studies, with first attempt success rates of around 50% in the neonatal unit and lower still in the delivery room. And for the most junior trainees, who often are being signed off as having met this mandatory competency, success rates were 24 to 38% on first attempt. And in the international study, 18% of intubations had at least one adverse event, and there was a severe desaturation in 48%. So these intubations aren't without risk. And when we looked at the 4 UK units, 23% of infants required 3 or more attempts before successful intubation. And in those units, there was 218 intubations, but they were shared between 122 clinicians, all competing to try and learn this difficult skill. And we know that most trainees report not being comfortable with intubation. So there was a survey of over 600 trainees in the UK and advanced neonatal nurse practitioners, which showed that only 18% said they felt completely confident with neonatal intubation. But despite this, 51% said they were supervising junior colleagues, and less than 50% have intubated over 20 times. And this is making intubation training very difficult. So there's not a set standard for how many neonatal intubations will make you a proficient intubator, but in the anaesthetic literature, over 40 intubations are reported to be required for proficiency, and that's defined as success rates of over 80%. And early failures are significant and can increase the number required to become proficient. And in a small study, they found that failure at the first 2 attempts would double the length of time to become competent at intubation. And then for general paediatric trainees, their training is then continually interrupted by periods where there's no exposure to a neonatal placement. So video laryngoscopy can be a potential problem by allowing supervisors to share the view with the trainee and give them direct advice on the anatomy and placement of the tube. It's been shown to increase success rates and reduce adverse events in 3 RCTs. There are differences in the blade size and shape compared to a conventional laryngoscope, and this means that it's a different skill for experienced intubators to learn and then learn how to supervise junior trainees in learning to intubate with this. And it's important to remember that although it increased success rates, this is in junior supervised intubations, doesn't necessarily mean that it's an answer to giving junior trainees the skills to intubate in an unsupervised way in stressful emergency out-of-hours intubations or emergencies. So we know that standardised supervision can increase success, and we recently published a quality improvement project that was carried out in Glasgow over the last couple of years. And we used evidence-based approaches to create a standardised training package and modify the environment. So along with use of a video laryngoscope, we had roles clearly allocated at the beginning of the procedure, with the supervisor taking overall responsibility for the clinical stability of the infant, and the trainee's only role being recognition of the anatomy and placement of the tube. And there was a pre-procedure pause and a checklist, an agreement for a clear escalation plan to the most senior clinician available if a 3rd attempt was required. Audience numbers were minimised, and trainees were matched to appropriate intubations with the knowledge that very sick infants, non-premedicated intubations and delivery room intubations would be more challenging and not appropriate for junior trainees just beginning to learn this skill. And we looked at success rates over the 2 years following implementation of these changes. and our junior success rates were increased by 50%, and the number of intubations requiring 3 or more attempts was reduced from 34% to 13%. But again, this was all in intubations that were standardised, controlled and supervised, and not an answer exactly to junior trainees having the skills to intubate in an unsupervised emergency setting. So are LMAs a potential solution to this problem? So LMAs are much easier to use. Their insertion is easy to learn for all grades of clinician, and their success rates are much higher compared to intubation. And in the Cochrane review, when LMA was compared to face mask, LMA can achieve effective ventilation in resuscitation and can avoid intubation in the majority. And when compared to intubation, there was comparable efficacy, and it was recommended as an alternative where intubation is unsuccessful. They're currently only licensed for use in infants over 2 kilograms. However, their use in smaller infants has been reported down to as little as 800 grams. And international resuscitation guidelines are now being updated to include LMAs. And in the last couple of years, updates have moved towards using LMA as an alternative to intubation for emergency airway management. And also, LMAs can be a potential solution for smaller units managing difficult airways and for transfer of infants. So the infant on the left-hand side was born in the north of Scotland at 32 weeks with an undiagnosed severe Pierre-Robin sequence. And he had 7 unsuccessful attempts at intubation and then was managed with an LMA. And he was ventilated through this for 4 hours until the transport team could arrive. And then when he was transported, he continued to be ventilated through this until he arrived at a tertiary centre. And again, surfactant is now being used in, LMAs are now being used in other ways, such as for giving surfactant without the requirement for doing direct laryngoscopy. And in units in the west of Scotland, this is now being routinely used for infants above 1.2 kilograms. So in summary, universal intubation competency is becoming increasingly not possible for all. So we can see that standardised interventions and video laryngoscopy in a controlled and supervised setting can increase junior success rates. But intubation numbers are falling and they're shared by many trainees, and those providing emergency resuscitation will frequently not be skilled intubators. So the future of safe airway management. So international resuscitation guidelines are now advocating LMA use as an alternative to intubation. And we feel that intubation should no longer be a mandatory junior competency. We would support the use of LMA being a mandatory skill for junior trainees instead. And smaller LMAs are urgently required. So that's a summary of our paper, and then we can move on to the discussion.
Thanks a lot, Gemma, for your presentation. For all the attendees, I would like to share that we plan to structure the discussion into 3 parts. So first we discuss the emergency neonatal airway management, and then elective management, and finally we discuss along the lines who should do what. If I may just start off with a first question of the more general kind. So your paper sparked a lot of discussion, foremost on Twitter that I follow, and were you surprised to see such a strong discussion, and have you met opposing views compared to your conclusions?
Yes, that was a bit of a surprise in some ways. Sorry. In other ways not. No, I've been talking about this topic for years, and it seems to be a surprise to people that even though everyone sees that there's trouble intubating, that we should ask a question. Maybe it shouldn't be a mandatory competency. Maybe we should do it a different way. I think it's a question that should be asked. I'm delighted it has generated discussion. As we were saying, we're pro doing this safely and protecting babies and protecting trainees. I think there is a line that the odds of a junior person succeeding in an emergency environment are now quite low. They're way less than 50%. So the odds of them not putting it in properly are higher than them putting it in properly. And I think the consequences, both for the baby and the trainee in that setting, are very severe. We need to ask, is there an alternative way of managing that situation so that we protect both parties? And that's just the aim. That's what we're doing. It's for future generations. My generation grew up intubating meconium babies. We won't have an issue with intubation, but Gemma and Alex's generation are different.
Yeah, I absolutely agree. I think it's great that it's generated discussion because it's kind of been the elephant in the room, the big unspoken, for quite a long time. As Joyce said, it used to be that we intubated meconium babies, we intubated anything under 28 weeks in the delivery room as routine. That's not the case now. We're moving towards much more non-invasive ventilation, LISA procedure, which actually requires almost a higher skill of intubation because you're trying to pass the catheter into a breathing infant whilst they're stable. And huge more numbers of trainees to treat more patients, to treat even smaller babies born at lower gestations, and there's fewer opportunities for them to learn. And then, as you've seen from our survey, people are getting to the end of training, and paediatric training in the UK is 8 years long already, which is longer than other parts of the world. And we're seeing people coming out of that training with fewer than 20 successful intubations. And I also worry about people's definition of competence. You've seen the hierarchy, we've all seen the hierarchy of competence, where I think being part of this, so being competent to do a procedure, is not just knowing how to put the tube in, but also knowing how to manage the team and how to manage it when it doesn't go well, and knowing when to stop and what your escalation strategies are and alternative strategies are. And I think until you've been in a situation where it's been difficult a few times, then maybe you're not quite there yet with the competence. You may be more in the unconscious incompetence stage.
Stefan, I think you're muted.
Sorry, I'm back. So beginner's mistake. So I'm coming then to the question of emergency neonatal intubations or management of the airway. How could management be secured or structured to ensure that a preterm baby or a term baby would have a secured airway under the current conditions, with few intubations, pediatric trainees maybe not training intubations, etc., etc.? How can we sort of secure it from a systematical viewpoint?
I think in the emergency setting, I think we're centralizing preterm neonatal care as much as we can, and we do really need to recognize how important it is to get the baby born in the appropriate unit. I think term asphyxias will happen in all different settings, and most preterm babies, even if they're born in a non-tertiary centre, will come out vigorous and crying. And I think centres should be prepared to support them without intubation. There's sometimes just the assumption they'll have to be intubated. But I think these are questions that need to be asked. We can't just say preterm babies are sometimes born in small hospitals, therefore intubation has to be there. You know, we have tried hard for a long time now to come up with a way of making this really easy. And you simply need practice. You need a certain amount of practice. We've all agreed you need, you know, quite a few intubations. People are not getting them anymore. So I think instead of kind of stamping up and down saying, but it is just needed, we need to start looking at maybe there's different ways to deliver this. You know, maybe we need to centralize further. Maybe we need to utilize transport teams in a different way. Maybe we need to utilize anaesthetists in a different way. Maybe we do need to be more open towards ventilating babies through LMAs for longer and do all the research to support all of it. And we definitely urgently need smaller LMAs. That goes without, you know, that's an absolute given. But I do think we can't just say it just has to be and accept it that way. Does that make sense?
I think as well, just being probably a more junior person, I think that most people at my stage know that they can't do it. And a lot of the big stress and fear for people who are kind of in their second and third years of paediatric training is that you'll be expected to be able to do this out of hours in a small unit because you've had the box ticked at some point in the early stages of your training. And I think that we all know as junior trainees that it's not something that we're able to do. So I think with it being an expectation, it puts a lot of pressure on trainees that know that they're not really able to do this.
Yeah, I agree with you, Gemma, and I feel that as a more senior trainee as well, that as you get more senior, that expectation of competence rises, and we certainly haven't had the number of procedures that our predecessors have. When we're talking about emergency intubations, I do feel that it potentially should be a more senior person attempting, with the risk of failed attempts making it harder for subsequent people to then be able to get the tube down. But I also think a clear plan of how to escalate supporting the airway is important. And we rely heavily on UK and the NLS, and I think in other places on the NRP to teach that. And actually that's one day every 4 years that we have to go on or teach on. And I think maybe regular practice on our units and simulation does have a big role there, but can't be the only thing that teaches people.
Yeah, I guess simulation is very good and very supportive, definitely for teaching people factors and teamwork and communication. LMA insertion in a simulated environment does seem to translate into clinical success. Intubation has not been proven that way. In fact, the studies that have looked at it have found the opposite. Intubating in a simulated controlled environment is exactly the same. It does not necessarily translate into that stressful emergency setting.
And when you're intubating in a simulation, you're intubating a mannequin, and there automatically is that relaxation there. And in real life, there's a lot more escalation of emotional factors, of anxiety. There's probably more people watching, and it's very hard to get a simulation that exactly reflects that. It's the one procedure, isn't it, that if you fail at doing in that moment in time, somebody could potentially
die,
pass away unless you've got an alternative. And that's not the case with cannulation, with putting a UVC in. So it is one of the highest stress procedures that we do.
It is, but I think also, we've all come across situations where there was multiple intubation attempts, and then you sat back and go, actually, could we have managed that baby without an ET tube at all? And I think in a lot of the situations we see these examples of where people get stuck in the minute and they just keep trying. And, to be able to stand back and, I don't know, there may well be changes in practices in the future. Teleneonatology may well be a thing, and you'll have other people there with you. But we want to question the approach to it all. I firmly agree with Alex's point of, while yes, we need to ask questions about emergency settings all around the place, we definitely do need to protect our neonatologists of the future. 22, 23, 24 weekers, sick babies will always need to be intubated, and they need the skills to be able to do that competently. So they need to have, priority over getting the number of attempts they need to be able to get that level of expertise that they absolutely need.
So if I, for example, would be working in Hospital X and we were considering to launch like a guideline how to do elective emergency management, and we have anesthesiologists, pediatric fellows during the nights, LMAs, and the regular equipments. How would you like us to phrase such a guideline? And who would be involved in doing what in an emergency? Because in an emergency, you can't wait for a transportation team that comes 2 hours later.
Yeah. It depends. It depends on the level of trainee that's there and their own comfort level. I think if a person is an experienced intubator and a baby is compromised in front of them and not breathing and mask ventilation hasn't been effective, I think it is entirely reasonable to go ahead and intubate that baby. But I think there needs to be a consideration for, if that person isn't an experienced intubator, and then different pathways to go down, for example, in LMA. With specific wordings, we have a guide. There's a BAPM difficult airway guideline where it has been worded. We have a local intubation guideline where, again, we have worded this. We have specifically said for micro-prem delivery room intubations, it needs to be a senior intubator only. We've been a bit more vague as to what exactly a senior intubator is, but it would be a senior trainee and more senior, or someone who has really logged enough of attempts and is confident that they can get it down. And that's with a very clear escalation plan. That's the other area we found that people weren't paying huge attention to. Okay.
Yeah, I've certainly felt as well, if I'm working in a hospital which has a clear difficult airway plan and escalation plan, I actually feel more relaxed when I'm trying to intubate, in the knowledge that any intubation can turn into a difficult airway. I feel more exposed if there's no clear plan and no difficult airway equipment available. So I think that's kind of a base for any hospital, is having a plan that works within your setting, not one size fits all, but something that works within the workings of that hospital, agreed by the stakeholders within that hospital.
Yeah, I think LMAs being in a difficult airway box is maybe something that should be expanded on a little bit. We have them in all of our resuscitators, and we have them in every ICU cot. They're in every airway trolley that we've got. I think it needs to be more than there's one in a box somewhere in the corner of the unit. But I think, yes, as Alex saying, there needs to be a clear plan for what you would do. We need to talk about these situations and write them down.
There is one question in the chat here about, or a comment about LMAs. Would you consider it to be definite airway securement? Is that how you would see it, or is it a temporary thing until someone else comes along?
I think that's an area that needs further research. Definitely, we have had experience of ventilating babies through them for numbers of hours. There has been case reports of babies being ventilated through them for days. The cases we've had so far in Scotland have been the can't intubate difficult airway scenarios, but the babies have ventilated through the LMAs absolutely fine. But it is, of course, that it's an area that there's very little research has been done. But it's a question that needs to be asked, because if you're going to use them more as a stabilizing tool, and you can trial then extubating the baby back off them, but if they don't manage, they'll go back down and they'll need to be ventilated through them for a while. But definitely our experience is you can ventilate through them for at least hours without issue. Gastric distension, I guess, is what could happen, and you can't put an NG tube down through these LMAs. But what you can do is take it out, just deflate the stomach and then put it back in. I wouldn't advise putting it down behind, because you could cause an esophageal perforation. But definitely it can be a measure that'll last for more than the delivery room if you wanted to.
So let's move on to the elective situation and planned management, whether it's intubation or, well, something non-invasive. How would you yourself like to, what would you like to stress as the most important escalation pathways and systematics around elective management?
So Gemma mentioned the QI project we've just published. So we've done all this work in Glasgow in the last couple of years, basically taking all of what we've learned from the studies and trying to make it into more clinical real life. The video laryngoscope has helped on every level. Now we have better success rates with the video laryngoscope than without, not just in junior levels, but it did take a while for people to embrace the technology because the blades are different. We have definitely found that in the NICU, when they're premedicated intubations, you can get success rates right up by paying attention to the factors we've identified as being what stresses people out. You know, baby becoming unstable, lots of people staring at a junior person, putting pressure on them. Problems with the premedication, you know, people who have a rigid chest with fentanyl, stuff like that, people definitely don't like that. Delivery room setting. So we don't let them start in the delivery room. People have had to log some intubations on the unit first. What we're not in agreement on is how many you need. But again, there's more work to be done. And then we have a very clear escalation plan that the third attempt is the best person on the floor. Even if you have to get them from the other side of the floor, that doesn't necessarily need to be the clinician who's looking after the child. And we very much encourage a call for help mentality. We have used LMAs as a way of breaking stress in a multiple attempt intubation, and that seems to work quite well as well, just as a temporary measure to calm things down. We have a big group with lots of complicated airways.
Sorry, in Oxford, sorry, I'll cut it off too soon. I'm sorry about that. In Oxford, we've definitely read your paper with great envy and thought, how can we implement some of this quickly? We've got an intubation checklist now, kind of pathway, but we're still very much facing this pressure from these rapidly rotating junior trainees who have to get a certain number of intubation, or have to get one. It's one that they have to get at level 1 logged on their electronic portfolio. Oh, can I do this intubation? Can I do that intubation? They put a lot of pressure on the middle grade or the senior trainee to have a go, and you almost feel mean saying, actually, no, I think I need to do this one.
Yeah. We have tried to turn that around. That intubation is done in a mannequin, and we're pushing pressure on the college for that not to be needed at all, because I think that one intubation doesn't give you anything anyway. And what we are trying to encourage is our middle grades and even our consultants to say, actually, no, I need this one. I need to do some. I haven't done some for a while, and the priority be training the senior people more so than the junior people. Our juniors are trained with LMAs. And some of the juniors will not do any intubations at all.
I think we saw that when we first started looking at the success rates in the 4 units in the UK, that actually a lot of them were being done by junior trainees, and actually the middle grades were doing very few because there was a pressure to give any opportunity to the most junior person so they could get their box ticked. And actually the middle grades who were soon to become seniors weren't really doing very many of them at all. And their success rates were very similar to the junior trainees.
I'm seeing that there's loads of questions coming through.
Yes.
Do you want to answer some of them?
Yeah, I think we can. So there's one in the elective context. There's one about pre-medication. Another one that keeps coming back is about the escalation. I mean, how do you escalate in practice? And the third one is about LMAs. I mean, how small babies are you using LMAs for? Do you see differences between the various types available, and can they also cause laryngeal edema, complicating intubation later? So we take pre-med, escalation, and LMAs.
So pre-med, I think, should be actively encouraged wherever possible. We definitely use them for all of our intubations on the unit here, and we have a fast drug pack, so they're pre-made up and it's very quick to draw them up. For delivery room intubations, we don't use pre-medication, except for if the baby has a diaphragmatic hernia, in which case we'll put it in very quickly. But on saying that, we do very, very few delivery room intubations. So almost all of our intubations are pre-medicated. Which pre-medications are best is, again, a whole other different argument in a different debate, and we're not going to go there. But I think pre-medication is the way to go. Escalation.
That's a separate journal club.
That's a separate journal club. The escalation plan. So, like we basically stole off an anaesthetic algorithm by the third attempt. It's the best on the floor, and that kind of has seemed to stick in. I think there needs to be a question about, for the first attempt, who should go for it. In a controlled elective environment, like those babies that were being intubated for surfactant, which are now fewer and fewer and fewer, they are suitable for whoever can be well supervised during them. But for babies with severe lung disease, for very small babies who are at risk of IVH, we need to be sensible, and it is about treating the baby comes first, and training people is very important, but it is second. But I definitely think you shouldn't have the same person trying over and over and over. I think you should be striving for all attempts to be a first or second attempt. The third one was laryngeal edema with LMA. We've definitely not found it, and there's no reports out there on it. We have had an isolated episode of esophageal perforation. Now, it was a complicated resuscitation, and the baby had lots of different instrumentation of their airway, laryngeal masks, oropharyngeal airways, laryngoscopes, ET tubes, NG tubes, and Rapogal tubes. But it is entirely possible that the laryngeal mask caused it, and it is a recognized complication of it. There's lots of recognized complications of laryngoscopes misplaced and ET tubes misplaced. But it definitely is not something that comes up regularly. When we had our esophageal perforation, we contacted the big LMA people worldwide, you know, Daniela Trevisanuto in Italy, who's been using them for much longer than us, and Carrie Roberts in the States, who is a lead for LMA surfactant, and they haven't come across it. So the baby that we had as well did have some dysmorphic features and had 11 sets of ribs. So it is possible that she had a weakening back there. So it's definitely not a common occurrence.
And how small babies do you use LMAs for?
Sorry?
How small babies do you use LMAs for?
So for the resus guidelines in the UK will say for officially 2 kilos, and then in their smaller prep they say, or maybe 1.5 kilos. Electively in our unit, we use it from 1.2 kilos and above to give surfactant. Again, we try and follow NLS guidelines for resuscitation, but we have had situations with babies smaller than that and trainees that need to, you know, resuscitate a baby and they'll put it in. We've seen that. We've not had difficulties with it. It's put in very carefully. So we've used it in practice at down less than a kilo, but it is with a small number of babies.
Cool.
And we've treated about.
Are you aware of any smaller LMAs coming out?
I've heard they're in development, but I've not seen them. But I have heard they're in development. Bring them on and bring on the trials that they'll need.
Yes.
I mean, it seems somewhat crazy that the smallest babies are the most difficult to intubate, and that's where we don't have a device to help us do it. It seems like a gap in the market for a company there, but I'm totally not business-minded.
It'll show you how low priority we are for companies that manufacture medical devices.
Yeah. So shall we come to the training part? I mean, who shall be doing what? And we had one question, which is obviously interested for fellows, pediatric fellows, and neonatal fellows, and that is, shall we be practicing intubations on animals? Is that something you do or would like to explore, you think?
We don't. I think logistically it's very difficult. You'd need an animal lab attached. Not many hospitals do. There is animals with comparable anatomy. Then you have to have the pre-med discussion there as well. I think for it to be a feasible large-scale thing, I think it's not an answer. In certain situations perhaps, but the same as it comes up with about practicing on deceased babies, and again, it's not feasible, it's not realistic.
Okay. In the Slido question, the majority suggested that pediatric trainees should be practicing and learning intubations, but I think you disagree on this point. How do you do it in practice in your hospitals?
I guess in an ideal world, yes, it would be lovely if everyone can intubate it. You know, it's not that we're being, you know, bold or cruel here. It's that you have to balance the risk of, is it possible for them to all learn intubation? And if you try and train them all, are you denying the future neonatologists? And I think we are. So I think you have to focus on the people that need to, and then you have to come up with a safe way of delivering airway management for everybody else.
Yeah.
I think if you have done a handful of intubations, you're possibly more dangerous trying to intubate than if you haven't, and you've been taught how to do good airway management, you know, without an ET tube. I think you will be safer not using an ET tube in that setting.
Absolutely. I think part of the competence
are future trainees as well.
I think part of the competence is knowing when to stop, and that's very rarely taught and not very frequently practiced either. I think the numbers speak for themselves. In our survey for success, we actually allowed 2 attempts, which is often what happens in practice, a little more pragmatic. And the numbers are speaking for themselves, that we're having more and more senior trainees with fewer numbers of attempts and lower success rates, low confidence rates. And what we're doing is producing a generation of consultants who are going to have to look after 22, 23 weekers who are not confident in intubation themselves. And these are going to be the people who are kind of the last bastion, the last people who are called in. So I think we do need to have the discussions, and now's a good time.
I think the level of success rates that we have with neonatal intubation, if that was in the adult world, there would be outcries. Like none of the levels of clinicians that have been assessed in the studies, and the Near-Fineo study from the States was a large study with 10 centers worldwide, and even the most senior level of clinician did not have success rates consistent with proficiency. You know, so technically none of us are able to intubate. You know, if that was the case in adult anaesthetic world, there would be absolute outcry about it.
Yeah, and you see the anaesthetists all have their logbooks and their number of successful intubations, and there is no formal process in place at all, at least in the UK, for neonates people to even have to keep up some sort of level of competency per year, even at senior level. It's left very much to the individual.
Do you think there is some kind of risk that to become a senior and experienced person, you need to have been junior and unexperienced? Do you see, and in a situation when we intubate less and less, do you see a risk that also the senior persons will be less skilled in airway management?
That's what we're talking about. You know, if they get a handful of intubations over a very prolonged period of time, it'll take you a long time to get there. And again, if you have a negative experience early on, it will take you even longer. What we're proposing is starting people more senior, but then they would be able to have more intubations in a shorter period of time and teach them with a video laryngoscope in a controlled environment and get them good before they're left into the emergency environment. I do think if it's done properly, you'll get there before you're...
We lost you.
I see this mention of ANNPs in the comments. I think ANNPs are a massively valuable resource in terms of both intubation training and also intubation success rates and competence. And some of the ANNPs that I work with are some of the best intubators I've seen.
When we've looked at the success rates in Glasgow, I think because the NMPs are a constant who are always in the units, and because you've got, you know, trainees are changing every 6 months, and then we'll go 6 months without seeing any neonates, we can see that the NMPs are very quickly able to get very skilled. And still looking at the success rates in Glasgow, it's very unusual for an NMP to need more than one attempt, which is very different to all grades of trainees.
So, do doctors need to learn to intubate? Wouldn't it be better to rely on neonatal nurse practitioners that are available in many countries? Not in Sweden, though, but in the UK, I know, and the US, of course, Canada, I think. What do you think?
I think each unit is a bit different, and, you know, staff that are on the unit all the time are easier to train, definitely, than staff that come and go infrequently. But not every unit has advanced neonatal nurse practitioners. They work on different levels of the roster. So it does a bit need to be fitted to what the unit has.
I think sorry, go ahead, Gemma.
No, that was me.
I was going to say anything. No.
Sorry, that was me. And I think also the issue is similar to in a way to the senior people maintaining their competency, right? So it feeds into the argument, Joyce, that you've been saying about actually future neonatologists and ANMPs. They're both permanent members of staff, and actually at some point, well, I know that the success rates in Glasgow sound brilliant. However, at some point, you know, we are training other people, and so when do we, like the consultants, get those attempts? And that's often in that, like you said, that's in that last ditch with the most senior person on in the middle of the night at a 23-weeker. And actually other people have been having those opportunities before. So I guess it's like what you were saying earlier about kind of consultants maintaining their skills as well, and how that is prioritized. But I think these are difficult conversations, aren't they? Like you said, but they are ones you can't escape the fact that we're intubating less, and perhaps it's less about intubation. And who's training us with LMAs? I guess who you're going to have to come to all the units, Joyce.
Well, it's part of the NLS course.
NLS.
Yeah, and it's part of our Scottish resource course up here as well. And you can train someone to use an LMA in 10 minutes. You know, that's the big difference. They won't get you out of every situation, but they're a useful tool if you're in trouble, most certainly.
We have incorporated it into our ANP program at Southampton. They have a difficult airway kind of sort of scenario station in some of their training, so that is obviously included. So I think it's a start.
Let's come to the topic of video laryngoscopy, because that's also related to who is doing and what shall we do. So one question here from in the chat is, what has been the minimal weight that it's possible to use it for? How small babies can be video laryngoscoped?
It depends on the device you have. The Infant View has a 00 blade. You can go as small as you want. The CMAC doesn't, so then you can't. There's a new glide scope out that has a 0 but not a 00, but you can definitely go down less than a kilo with it. We keep saying to them that they need to get the blades better, but it is coming. I think in another 10 years we'll be able to do it with a small, tiny Bluetooth device, and it'll be fine.
And we will be using our iPhones. There will be an app.
I think that's another question. The whole, because you could supervise an intubation virtually, and that can get you a more supervised person there. But you need to have a plan for what happens if the tube doesn't go in.
Yeah.
And I think you mentioned in your slides, Gemma, that video laryngoscopy and direct intubation are obviously very different for anyone that's used a video laryngoscopy. The technique is slightly different, isn't it? Do you feel, as a panel, that people need to be able to do both? If you're training with video laryngoscopy, is there a risk that people then won't be able to intubate in another way if they don't have it available? I don't know. What are your thoughts there?
There is a Canadian study that has looked at that, Musa et al., who did one of the RCTs, and they found it did translate. They used a CMAC. We, for junior trainees, say they have to intubate with a video laryngoscope, and once they are skilled, they can intubate with what their preferred device is. I think, again, when it comes back to the baby, we can have better success rates with a video laryngoscope because you can share the view. I think the biggest issue is the lack of recognition of the anatomy. Again, we found that when we looked at unsuccessful attempts, people aren't recognizing the structures in front of them. A video laryngoscope can help point that out. Definitely, again, like if you're teaching someone and you can get them up that curve quickly by starting off with a video laryngoscope, and then I do think it does translate, yes. And I'm confident the technology will continue to improve. I imagine with time the video laryngoscope will take over completely, as it largely has in the anesthetic world, but I don't think we're there yet. But I do think the technology is getting better. The question, of course, is whether or not it improves senior success rates hasn't been asked yet. And Cochrane has asked that we do.
So do you think that if we come to neonatal trainees, I mean, I suppose you agree that neonatal trainees should be practicing intubations. Do you think that the training in neonatology should include pediatric anesthesia as a compulsory rotation? Does that help, you think? Or is it still too different?
It would be helpful if it's possible, yeah. We send trainees to anesthetic lists, but again, they don't intubate very much on them either. They come back with better LMA technique. And it is bigger babies and stuff. I know when I was training, I wanted to do an anesthetic rotation. I was told I wasn't allowed.
Yeah, it's tricky here as well to negotiate. But I do think we've got a huge amount to learn from the anaesthetists in their procedures, their processes, how they choose their drugs almost per patient sometimes. But I'd very much welcome collaborating a lot more with them and developing how we intubate babies and how we teach people to intubate babies.
I think
sorry, please.
I think the anaesthetist would also have something to say about our just, multiple attempts, and we just keep going and going, and we let their sats drop down, and that's normal.
So we have soon been online for an hour, but before we finalize, what would be your most sort of important take-home messages for all the attendees in this webinar?
Okay, I guess intubation can be made more successful and safer. A video laryngoscope definitely does help, but the evidence is that it helps in supervised controlled intubations. In the emergency setting, you need to have a plan and a backup plan. And we do feel laryngeal mask airways are a relevant tool there, and one that will be used more and more. And we do think trainees should be competent and comfortable with using them. Alex and Gemma, have I got it? Is there more?
Yeah, absolutely. The only minor point I'd add is just taking this information and having starting to open up those conversations and have them about the dwindling numbers of intubations and reduced training opportunities, and what's going to work in Oxford in the UK may not work in Sweden, may not work in Australia, but starting to have those conversations at local and national level can only be a good thing for babies.
Yeah, no, I would agree. I think as quite a junior trainee, I think it's important that we get a chance to kind of say ourselves as junior people that we don't feel confident doing this, and we need to have more of a discussion about these issues just for going forwards.
Thanks. So a systematic approach to this area is important. And when it comes to more research, people tend to say more research is needed all the time. And I start to get a little sick and tired about that, because I think we need more quality improvement. Would you agree that we need more quality improvement in this context about this airway management context, or do we still need a lot of more research?
I think there is more research that needs to be done. I think these smaller LMAs will appear on the market, and then I think they need to be tried in big trials before they're just, automatically taken into practice. I think the full role of the video laryngoscope, again, needs to be asked in trials. But I think, yes, quality improvement is very important. And that's what our most recent project was taking what's out there and implementing it into clinical care in a real life setting. And we did find that it works. I would love to have more data about how many intubations people are doing, what success rates are like in smaller units. There's nothing out there on that, where I suspect the problem is at its biggest.
Maybe that could even be like a small study on Twitter. I mean, there's quite a lot of neonatal professionals of all categories present on Twitter. So maybe that could be a proposal to you, that you launch like a Twitter survey of some kind to gather data. Because I agree, there's lots of things that needs to be known, of course, especially about the non-level 3 context where babies are also born and having difficult airways sometimes, as you know.
I am absolutely delighted, though, by the interest this has generated, and we will keep asking these questions, and we are delighted that people are giving opinions and listening to us and agreeing with us and disagreeing with us. It's all good, but I'm delighted that we're talking about it.
Thanks.
It's fascinating watching the chat.
Okay, so thank you. Sorry, please.
No,
okay.
I was just going to say, yes, the chat, there's a lot of things, Alex, I think that we haven't quite managed to get round to answering, but maybe we can put something together for the 99 NICU forum to address some of the things we haven't mentioned.
That's a good idea. In the Journal Club thread would be a good place. Okay, so thank you everyone in the panel, and best regards to Charles Rohr as well, who couldn't attend. And we'll see when Francesca Dona in Vienna is able to reconnect with us after this meeting. He's on the unit. So thank you so much. I would also like to say thank you to all the attendees. A lot of people has been joining. And we have also recorded the session, as you know, and our plan is to make it available on YouTube, so it could be shared. We will check with you that it's okay first, of course, and we will also look at it afterwards to see that it's okay for sharing. So thanks a lot, and wish you a nice evening.
Thank you, everybody.
Thank you, everybody.
Brilliant. Thanks very much. Thank you.
Bye.
Thank you.
Bye-bye.
Have a good evening.
Bye.
Bye.